Artur, Dr. Professor Godnicki. It's a pleasure to be here. This is my third trip to Poland, third trip to beautiful Krakow. During my last trip, if I can go back on my slide, I'm the one on the right, in case you couldn't tell. But Artur was kind enough to take me to my hometown of my father when I was here the last time, which you'd have to ask him where it is because he took us, it was like 2.5 hours from here. But I actually got to visit the birthplace of my father when I was here 2 years ago. So I'm almost a true Krakowian Polish physician. I just haven't been in the United States for my whole life. So today I have the pleasure of talking to you about newly diagnosed myeloma. We're going to cover a couple topics that are relevant to newly diagnosed myeloma, papers that just were published. The first question we've got, it's a case study, kind of in the typical format of grand rounds, at least in the United States, and it's to serve a purpose to teach you about one of the new issues about the criteria for diagnosing myeloma. Then we're also going to talk about the new staging system that was just published 4 weeks ago. So we have a 52-year-old healthy male, presents with bone pain. His MRI shows an abnormal bone marrow signal, but he has no lytic bone disease, no focal lesions, just an abnormal marrow signal. Has a workup. He doesn't have anything on his serum protein electrophoresis. He's got normal renal function. He has normal calcium. He's mildly anemic with hemoglobin 12.3, although his previous hemoglobins were only 14. So this is still not a 2-gram drop in his hemoglobin, which would meet the criteria for significant anemia. Beta 2 micrograms, 2.2 milligrams per liter. Albumin is normal range. He does have free light chain assay done, and he's got a ratio of over 100. He has no evidence of hemolysis, no evidence of blood loss. He has a PET and an MRI, and he finds no other lesions on these radiographic evaluations. His bone marrow shows 65% plasma cells, but he has normal cytology, and his FISH analysis is negative for any adverse features. So the question is, what does this individual have? So in the past, not to torture anyone here, in the past, we would have all agreed that he has no CRAB symptoms, no hypercalcemia, renal insufficiency, anemia, bone disease, and he would meet the criteria for smoldering myeloma. Based on the new criteria that was published last November, I think, this is now considered to be myeloma which does require treatment. One of Dr. Dispenseri's colleagues at Mayo Clinic has defined this as slim myeloma, which I'm going to show you in a second. So this is a patient who would, in our current recommendations by the International Myeloma Working Group, of which all the speakers, or close to all the speakers, are members, would recommend that that person be treated. This is all old data that you've seen in the past that Dr. Kyle has specialized and published for many, many years. The issue with smoldering myeloma is there's about a 10 to 15% likelihood of progression within the first 5 years, and then after that actually decreases to 2 to 3 years. And in reality, these patients who have these late relapses are probably really, biologically, they're probably more MGUS. You know, the cutoff for smoldering myeloma versus MGUS is 10%. So if you're 10%, you have myeloma. If you're 9%, you have MGUS if you have no other symptoms. So sometimes there's a little leeway there on what the diagnostic criteria is. But this is the typical evolution of patients with smoldering myeloma. There is a group of patients who have a much higher risk of developing myeloma, which is symptomatic in a short period of time. And if you look at free light chain ratios, and you look at the likelihood of a free light chain ratio of over 100, time to progression is 15 months, less than 100 is 55 months. So it's a big cutoff here of free light chains over 100, which is one of the criteria that was used. When you look at plasma cells, this is mainly work done at Mayo Clinic by Dr. Dispenseri's colleagues, and I'm sure she's one of the authors on these papers. If you look at over 60% versus less than 60%, you see an obvious difference. So the International Myeloma Working Group, and Vincent Raj Kumar, I think, is the first author, came up with criteria to include patients who have high-risk smoldering myeloma, that being defined as more than 80% chance of developing symptoms within 2 years, should now be considered myeloma patients who require treatment. So that small group, it's only 15 to 20% of smoldering myeloma, that high-risk group is now considered to have myeloma, even though they don't have CRAB symptoms, that does require treatment. And that's what's shown on this slide. This is the typical MDUS definition. This is smoldering myeloma. The top half of this slide, of this particular box, is what the previous criteria were. And now we have added these criteria: clonal plasma cells of over 60% or serum free light chain ratio of over 100. And I didn't show you the data, but it's just as convincing if you have one or more lesions by MRI or PET CT. You probably should treat these patients. So the question always arises, and I've seen patients like this, and I'm sure all my colleagues have seen patients like this. Well, I found somebody who has a free light chain ratio of over 100 for 4 years. Does that mean you should start treating them now? And the answer is obviously not. But if you have someone that walks in the door that meets this criteria, and they have an 80% chance of having end organ damage, the current recommendations of those patients should require treatment. And then once you start their treatment, and my colleagues could give you their opinions during question and answer, but once you start treatment, you treat them just like you would any myeloma patient. So if you're inclined to give induction therapy followed by transplant, induction therapy followed by consolidation or maintenance, whatever you want to call it, once they are put on the pathway, you would treat them as you would any regular myeloma patient. The revised international staging system came out a month ago. And with this staging system, there was 4,000 patients that they looked at, and about 3,000 of them, they had adequate cytogenetics, and they had adequate FISH, and they had the LDH levels. And they did a statistical modeling of the previous ISS, which was obviously based on beta-2 and serum albumin, and they incorporated LDH, cytogenetics, and FISH. And the FISH criteria were 414, 14, 16 translocations, and 17 P deletions. And then if you had an LDH over normal range. And they came up with the new criteria that stage 1 stays the same, including the fact they have standardized cytogenetics based on FISH, and they have a normal LDH. Stage 3 is the typical serum beta 2 microgram over 5.5 milligrams per liter, and high-risk cytogenetics or high LDH. And this is the new criteria that just was published for staging. What does the data show on this? There's a lot of information in this slide. The top graph is the overall survival based on the revised ISS, ranging from patients who now have revised ISS of 41 months versus those who have stage 1, which is 66 months. This is in the non-transplant group, and for any of those here who are not advocates of transplants, this is the group that got transplanted. This is not a randomized trial. This is just database analysis. For those that are complaining about my statement, but this is the group that had transplant. Interestingly, patients that have the third RISS3 essentially have the same outcome with or without transplant based on this data. But if you look at the patients who have 2 and 1 stages, they are significantly better than what you see in patients who did not have transplant. They also divided up in one of the other parts of this paper, whether you had a proteasome inhibitor or lenalidomide as their initial therapy. And again, the stages all split out very nicely in all of those drug treatments. And actually, the lenalidomide and the proteasome inhibitors had almost identical curves. They were almost superimposed on each other. So the first thing you have to decide when a patient comes in, and because we're in Europe, we're not in the United States, where our version of socialized medicine, Medicare, doesn't have any upper age limit for transplant. So you can have a transplant in the U.S. at any age. It's not the typical European, which is 65, unless they're in clinical trials, and it's not true all over Europe, but in general, it's the 65-year cutoff. So the way we approach patients in the U.S. is quite a bit different than the way you approach patients here. So one issue is the issue of transplant. The second issue is availability of what we still continue to call novel drugs, which are the immunomodulatory drugs and the proteasome inhibitors, which are readily available in the United States and not readily available here in Poland. So depending on what you have, you may get, actually most people do not require 4 to 6 cycles of therapy. Most get maximum benefit of 3 to 4. You collect their cells, they have a transplant. There's a recent push, mainly based on the Italian and French studies, of giving consolidation therapy for 2 to 4 cycles. And then there's the issue of maintenance therapy after transplant. If they're not transplant candidates, induction therapy followed by, and it depends on how you want to define it, whether you want to call it continuation or if you want to call it maintenance therapy. But bottom line is you don't stop the treatment. And we're going to show you the data, which I'm sure you're all familiar with. So in patients who are transplant candidates, we have a number of issues. We have these regimens that we have. In the United States, most of us are given triplets. Most of those are proteasome inhibitor combination with immunomodulatory drugs and corticosteroids. So it's, in general, it would be bortezomib, lenalidomide, dexamethasone, although there are certainly pockets in the United States that use bortezomib, cyclophosphamide, and dexamethasone for induction therapy. Response rates are well over 85%, and response rates are seen within the first cycle of therapy. Depth of response, which we're going to talk a little bit later about minimal residual disease, appears to be a very important surrogate marker. Obviously, we want to improve the quality of life and functioning activity of our patients when they come in, especially if they have end organ damage. Stem cell mobilization should be done. And there's still issues at hand. If we get such good responses with novel therapy regimens, what is the role of transplant? Do we need a transplant at all? Do we need a transplant early in the disease course, or do we need a transplant late in the disease course? And then one of the issues which appears to be relatively resolved is how long should we treat patients for with maintenance therapy or consolidation therapy? So this is a slide that's actually a few years old, showing that the depth of response does translate in improvement in progression-free survival and overall survival. Patients who achieve very good partial remissions have better responses and longer duration responses than individuals who do not have a very good partial remission. Yet complete remission still appears to be the ideal approach and the ideal goal for the treatment of patients. When you look at phase 3 trials, and most of these were actually done in Europe, of different regimens, including bortezomib dex, bortezomib lenalidomide dex. We've got a couple trials. Some of these are, this is the Italian trial, Spanish trial, French trial, Dutch-German trial, and U.S. trial. Response rates of achieving very good partial remissions are actually very good. Much better than we ever had with the older regimens that were melphalan-based. When you look at phase 2 trials, you can see that the VGPR rate is even higher, and the most potent one appears. And again, these are only phase 2 trials. These are 45 to 55 patients in each trial. The most potent one with VGPR rates of 80% is KRD, which is carfilzomib, lenalidomide, dexamethasone. But these other regimens certainly are very, very potent regimens. The new one that's not too far away, I think, being approved by the FDA is ixazomib, which is the oral boron-based proteasome inhibitor, very similar, if almost identical, to bortezomib. It's essentially, although the company doesn't like it, it's essentially an oral Velcade or bortezomib. When you look at the regimens, including transplant over time, essentially all the newer regimens that we're using, which I'm sure that is being used frequently here, Velcade, thalidomide, dexamethasone. This is lenalidomide, bortezomib, dexamethasone. This is carfilzomib. Response rates are all 100%, and the depth of responses are actually all very, very good. So we have a lot of good drugs that we can use to treat these individuals. So one of the questions that's been raised and continues to be raised is, should you have a transplant at all, because we have such good regimens. I just showed you 100% response rates, 80% VGPR or better response rates. Should we do transplants? It's 2 weeks in the hospital. It's certainly a cost on the patients and the family as far as stress, physiological stress, monetary component too as well. So the Italian group published this trial by Antonio Palumbo. They gave lenalidomide, dexamethasone induction regimen. Patients were then randomized either to tandem transplant versus consolidation with his melphalan, prednisone, and lenalidomide regimen. And there was a second randomization to maintenance or no maintenance. So we have transplant versus no transplant in this population of patients. One of the complaints before I show you the results of this study was that there was not a proteasome inhibitor incorporated into the schema. So some people can say, well, that's great, but they didn't include both of the most potent regimens that are available, which are proteasome inhibitors with a immunomodulatory drug. And these are what the results showed. The progression-free survival was superior in the patients who had the tandem autologous transplant, and there was a trend to an improvement of overall survival as well in the patients who had the transplant. So transplant looks like it remains a very potent treatment modality, and at least compared to a pure immunomodulatory-based regimen was superior. This is a very important trial that's being led by the French group in combination with my colleagues from Dana-Fargo Cancer Institute. This is a randomized trial using combinations of immunomodulatory drugs and proteasome inhibitors, and this trial is not asking the question of should you have a transplant or should you not have a transplant. This study is looking at when to have the transplant. Should you have it as part of your initial therapy, or should you have it at the time of disease progression? So if I can go through this with you briefly, everyone's getting bortezomib dexamethasone for induction. Everyone's having their stem cells collected after their induction course. One group is having a transplant. They're getting consolidation with the same regimen as induction, and then they're going on maintenance therapy. And I'm going to talk about the duration of maintenance in just a second. This is the early transplant group. The late transplant group gets the same induction. They get their stem cells collected. They get 5 more cycles of consolidation with the bortezomib dexamethasone, then they go on maintenance. This trial has well met its accrual in France, and I understand it's not being presented at ASH, or it is, do you know, Ken? No? But none of
600 patients right now.
Okay, so it's not yet ready for being presented at ASH, but the French trial has met its accrual because the U.S. trial, the U.S. groups and the French groups disagreed on the duration of maintenance, and because the U.S. trial took a little longer to get started, there's now actually a second comparison that's going to be done that was not planned initially. The U.S. trial is going to be lenalidomide maintenance indefinitely. The French trial is going to be limited to 12 months. So we're going to have a 12-month maintenance versus an indefinite maintenance, French-U.S. So we'll answer early versus late, and the late group here gets a transplant later, and we're also going to have an answer, hopefully, to the duration of maintenance therapy, 12 months versus indefinite. What about tandem transplant? I spent 6 years of my academic career with Dr. Barlegi in Arkansas, where everyone gets 2, 3, 4, whatever number of transplants. But the intent of the initial induction therapy was to do 2 transplants. And there's still controversy of 1 versus 2. The old French and the Italian studies showed that a small subgroup of patients who did not get a very good partial remission with 1 transplant are the ones who actually benefited from a second transplant. Those trials were actually relatively small. The U.S. has finished a larger trial, 750 patients with 250 patients in each arm. So it's a much higher patient accrual. 1 arm is 1 transplant. Second arm is 2 transplants. The third arm is 1 transplant followed by consolidation. All arms are getting lenalidomide maintenance now indefinitely. So we're going to readdress the 1 versus 2 transplant issue, or can you give consolidation and avoid a second transplant? And this is the design of the U.S. trial. This trial has met its accrual. It's going to be evaluated October of next year, I think is the 3-year from the last patient in. So maybe, probably not by ASH next year, probably ASCO next year, we'll have some data on this trial. It's finished accrual. It's 2 years since the last patient was enrolled. So, role of stem cell transplant, in my opinion, it's still the standard of care. The standard arm in the French-U.S. trial is the early transplant group. The investigational group is the one that's getting late transplants. There is obviously novel agents have improved the outcomes. We were getting more and better minimal residual disease responses in these patients, and I'll show you in a second. We should really be trying to achieve probably a complete remission. I'll show you some data on that in just a little bit. And with the current therapies, with 1 transplant and consolidation or maintenance therapy, it's possible. This is a slide I borrowed. All the people from the U.S. have seen this many times. This is from Sagar Lonial from Emory University. He's talking about the disease burden. We've got our iceberg here with only thing that that we can normally see is above the water line, and then there's different levels of disease burden that we can now detect and get to lower levels in the iceberg based on different levels of treatment. So we know that even with complete remission, we still have 1 times 10 to the 8th cells. Stringent complete remission, normalization free light chains is another level lower. And now there's a further push on either molecular or flow cytometric minimal residual disease, which probably brings us now down to even a lower level of disease burden. Hopefully, we can actually speak without, being castigated by our colleagues of curing the disease in the not too distant future. So this is some data on different technologies to measure minimal residual disease. The 8-color flow, the Euroflow, that has been mainly studied by the Spanish, has certainly can show a difference between outcomes between MRD negative, MRD positivity. Next generation sequencing is becoming very popular in the US, just starting off the ground, which is another technology that can give you the difference between MRD positive and MRD negative. And then if you look at radiographically, you can actually see differences. Some of this has been done here in Europe, as well as predominantly by the Arkansas group, showing the difference in radiographic complete remissions. This is data that's actually a couple years old now, showing what happens with MRD. So this is a slide that shows MRD negativity with standard risk cytogenetics or unfavorable cytogenetics. And not to belabor this, but there's a significant difference in outcomes and progression-free survival, as well as overall survival. For MRD negative and have favorable cytogenetics, you have a significantly longer progression-free survival. You have a significantly improved overall survival compared to MRD positive or to MRD, depending on the cytogenetic risk factors. So one of the questions that we posed earlier was how long to treat. Thalidomide actually was the first agent that showed absolute improvement. For the more mature people in the audience, they'll remember interferon maintenance therapy, which actually did have about a 6-month, if you look at the old data, had about a 6-month or month longer remission duration, but at a very high cost to the patient. Thalidomide, if this is older data from Michelle et al., certainly did have an improvement in event-free survival if you're on thalidomide maintenance versus no maintenance. Of course, the more recent data is the French and the US trials of lenalidomide, a single agent, starting at 10 milligrams after transplant, intended to actually go to 15 if it was tolerated after 3 months. The French showed this data with improvement in progression-free survival of about 18 months. And the US data presented by Phil McCarthy now shows about a 26-month difference in progression-free survival on patients on lenalidomide maintenance. So there's no doubt that there's an improvement in progression-free survival. All the trials have shown that. The controversial area in maintenance therapy is whether there's a true overall survival benefit. McCarthy's CLGB trial did show a significant difference in overall survival. The other major transplant trials have not shown an improvement in overall survival. And that's what's shown here. The meta-analysis was 4 different trials. The overall summary of that meta-analysis is there absolutely improvement in progression-free survival. There was a trend, but not statistically significant, improvement in overall survival in this study. And what is the risk factor besides the cost? Myelosuppression, patients with the potential toxicities associated with the administration of lenalidomide, but then there's the small but distinct increased risk of second primary malignancies, which I'm sure you're all aware of. I'm not going to delve into. And this is both hematologic as well as solid tumors, but the hematologic were more impressive increase than the solid tumors. Well, we talked a lot about lenalidomide maintenance. What is the data on proteasome inhibitor maintenance? And that's what the next series of slides are. This is a trial that's actually fairly confusing. This is VAD. This is vincristine adriamycin dexamethasone versus bortezomib adriamycin dexamethasone. This is done by the Hoven German group. They had transplants. The Dutch had 1 transplant. The German group did 2 transplants. And then they went either on thalidomide or they went on bortezomib maintenance. And they did show that there was an improvement in progression-free survival and overall survival in patients who had bortezomib for induction and had bortezomib for maintenance therapy. So before and after use of bortezomib was associated with improved PFS and OS. There was a trial that was presented at ASCO just this past May, June from Straka, where they did a randomization to bortezomib or no bortezomib, a little bit higher dose, 1.6 milligrams per meter squared for 4 weeks for 4 cycles. So 4 months essentially of bortezomib after transplant versus observation. And they showed an improvement in progression-free survival, but when you actually look at the improvement in progression-free survival, it only amounts to about 6 months. So you put them on for 4 months of maintenance therapy and you get a 6-month progression-free survival advantage. Not sure that's going to go anywhere. It's not very easy to administer, and maybe this will be readdressed with ixazomib when it becomes available because it's an oral formulation of the boron-based proteasome inhibitor. There was no difference in this trial in overall survival. So there's certainly a PFS advantage. There's an overall survival advantage. There are toxicities. There's always the issue of generating resistant clones. If you put somebody on subtherapeutic doses of lenalidomide, it's possible that when they progress, whether you can increase that dose or add dexamethasone to it to see if you can overcome the resistance that developed at the lower dose. But that's certainly an issue that you may push the clonal evolution to immunomodulatory drugs by utilizing chronic subtherapeutic suppressive therapy. In the elderly, Dr. Colombo has been very prolific lately. I think he's publishing a major paper a week. He presented a study that was just published in Blood on frailty in elderly patients. Elderly patients obviously cannot tolerate same regimens or duration of regimens as easily as younger patients. So the question is do elderly patients have a different disease? Is it just because they have more comorbid medical conditions? Should you use the same 3-drug regimens or 2-drug regimens in the elderly? Does it matter regarding the depth of response in the elderly? So there's a lot of issues in the elderly. Given the fact that this is a disease with the average age of 69 or 70, this is a very pertinent thing. So he came up with this frailty score, which I'm not going to go into any detail, but there's actually a group of patients over the age of 65 that he calls either 0, which is fit, intermediate, or frail. And if you look at their overall survivals, 84 months, 76 months, 57 months, just based on their Charleston Comorbidity Index as well as their ability to perform their usual daily activities. And you can divide these patients. This has nothing to do with stage, it's nothing with cytogenetics. This has to do with their physiologic function. And this slide is way more complicated. I only show you that these 3 groups divide out very nicely regarding progression-free survival and overall survival. What about summarizing this in patients with renal insufficiency? They're more likely to have renal insufficiency. In the older patients, probably because of other comorbid medical conditions, their performance status is worse. They do have more frequent, more advanced disease. They, interestingly, do not have higher risk cytogenetics, different than AML, MDS, where you see increasing risk of cytogenetic abnormalities in those types of leukemias or pre-leukemic states. They did not see this, at least in their study with myeloma. And the efficacy differs significantly. So one of them was just based on their survival. When you look at the efficacy of drugs, probably due to the ability to tolerate drugs, patients under 65, patients over 80, the response to therapy is lower. The progression-free survival, 31 months versus 11 months. So elderly patients remain a challenge. Part of the challenge is morbidity, mortality in the first couple of months because they're older and frail, particularly over 80, 14% in the first 2 months versus 3% in under 65, which is actually fairly high. Yet, I just told you that maybe we shouldn't hit them so hard with therapy, but what happens when you do treat them with good drugs? And you look at progression-free survival based on the depth of response, complete remission rates have a far superior progression-free survival than patients who do not get as good a response. So this is really a difficult dichotomy in treatment decisions is you don't want to give them too much therapy because they're frail, but if you give them therapy, you'd like to give them a response, because if you get a good response, they're going to do better. So you see this with progression-free survival, you see this as overall survival. And this is based on 3 large studies using melphalan prednisone-based therapies done in the Netherlands and with the Jemima group. You're all familiar with MP versus MPT and various renditions of MP, MPT, or with combination with MPV. Interestingly, there's actually 3 trials now of MPT versus MPR. I know thalidomide is much easily accessible here in Poland than lenalidomide is. And just so you know, I'm sure most of you are aware of this literature, there's actually 3 studies of MPT versus MPR. Most of us would think that lenalidomide is by far a superior regimen than thalidomide. But actually these studies don't prove that point. So there is a trial that was done by the Dutch of MPT versus MPR, followed by maintenance with either R or T. The results were identical. There is an Italian study, the first study, which I'm going to show you in a second, MPT versus RD, came out the same if it was a limited exposure. And there's a third trial that was just published by ECOG, one of the cooperative groups in the United States, MPT versus MPR, outcomes were identical. So T versus R T is not tolerated as well, but the progression over survival, the response rates, and the overall survival are essentially identical of T versus R. What about 2 versus 3 drug regimens? This is a trial that's been published by Ruben Niziski. He was here 2 years ago. He presented this data. This is bortezomib dex, bortezomib flutamide dex, bortezomib melphalan prednisone. So we have 3 different bortezomib regimens, and the doublet did essentially the same as a triplet. So most of the time we think 3 drugs is better than 2. In his trial, the toxicities were much higher with 3 drug regimens than the 2 drug regimen. So the doublet actually came out the same in this group of patients who were not considered transplant eligible of just bortezomib dexamethasone without a third agent. Toxicities were higher. I already alluded to that. If you look at the toxicity profile here, any AEs over 3, this is the doublet, these are the triplets. The outcomes, the response rates, progression-free survival, overall survival were the same. Toxicities were higher with the triplets. This is a trial that you may have participated in here. Did you participate in the first trial? This trial asks 2 questions. One of them we already addressed. One is lenalidomide dex versus MPT is one of the questions being asked. The second question being asked is the duration of therapy, 18 months of lenalidomide dexamethasone versus continuous lenalidomide dexamethasone. Lenalidomide dexamethasone continuously had a far superior progression-free survival than either limited 18-month exposure to lenalidomide dexamethasone or MPT. This is the third trial I was alluding to that showed no difference between R and T. When they looked at overall survival, there's a trend to an improvement in overall survival as well in the patients who had the continuous lenalidomide dexamethasone, indicating you should not discontinue the treatment. What about in the United States? Less than here, because in the U.S. we use a lot of combination of immunomodulatory drugs with proteasome inhibitors. This is a way, dose modification of lenalidomide bortezomib dexamethasone in patients who were more fragile, older patients, and they had excellent response rates of 90% by giving a dose modification of this regimen. This is a paper Dr. Palumbo published a few years back on dose modifications of different drugs in our more elderly population. He divided them up 65 to 75 and over 75 on how to administer a variety of drugs. Exasumid, which I already alluded to, is the new boron-based proteasome inhibitor. It's oral version of bortezomib. This is data just to show you a hint of the future, because this is a phase 2 trial. There's only 34 patients on it, and only 20 of them, I think, or 21, actually got the maintenance. But they gave exasumid lenalidomide dex to newly diagnosed patients, and then they gave them exasumid maintenance therapy. So it was IRD followed by eye. And what they found in this trial was that they actually had a 48% further improvement of response when they went on the maintenance part of this trial. So the overall response was very good. It was 90%, which is what we see with almost always with immunomodulatory drugs combined with proteasome inhibitors. Yet they found a deepening of response with continued exacerbation by 50%. Small trial, it's only 20 patients. There's a large trial in the US which is completed its accrual that should be available in the very near future. We've already gone over this maintenance in the non-transplant candidates. Just want to bring up one more trial. You have another one by Dr. Colombo. This was a trial you're all familiar with. This is melphalan-prednisone versus melphalan-prednisone-lenalidomide. Limited exposure, melphalan-prednisone-lenalidomide with lenalidomide maintenance. And you're all familiar with these results, that the continued exposure to lenalidomide resulted in a superior progression-free survival, 31 months versus 14 months. There was no difference in overall survival in this group of patients at the time of the most recent analysis. So continued lenalidomide exposure did result again in improvement of progression-free survival in the non-transplant setting. In contrast to the trial just before this, where they had the lenalidomide and the dexamethasone that was given continuously, both the drugs were continued continuously. It wasn't just lenalidomide. This is lenalidomide as a single agent. The previous trial, the first trial, is lenalidomide plus dexamethasone. And we already went over that. So this is my concluding slide. It certainly appears that MRD is a surrogate marker for improved progression-free survival. Overall survival needs to be proven in randomized prospective clinical trials. There's an increasing interest in consolidation after transplant, followed by maintenance therapy, although there's really a French study as well as an Italian study, but the current large clinical trials are incorporating consolidation after transplant. Maintenance therapy absolutely improves progression-free survival, whether it actually improves the overall survival. Only the CLGB trial actually shows improvement. Lenalidomide continues to be the most studied agent for progression-free survival. Proteasome inhibitors are certainly closer, particularly if we can get pumped with an oral proteasome inhibitor, which looks very close to being approved sometime in the next 6 months. In transplant-ineligible patients, they should continue on whatever therapy they were on before. There's controversy if you believe the Colombo study where they used melphalan as a single agent versus the first trial where they used lenalidomide plus dexamethasone. Everyone should get the lenalidomide. Still kind of a toss-up whether you need the dexamethasone or not. And monoclonal antibodies, which I didn't talk about because we don't have any upfront data, but I'm sure Dr. Anderson in his next talk will talk a lot about monoclonal antibodies, but there are currently clinical trials of monoclonal antibodies in the upfront setting, randomized phase 3 trials. Daratumumab, lenalidomide dexamethasone versus lenalidomide dexamethasone is currently accruing patients. Elotuzumab, the SLAM7 CS1 monoclonal antibody, has completed a trial of lenalidomide dexamethasone plus elotuzumab versus lenalidomide dexamethasone. These may also change our algorithm of how we treat patients in the future. And with that, I will conclude. Thank you. I appreciate the opportunity to be here.